Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
I have a question going back what we were talking about earlier. We were talking about pterygoids and traditional all-in-4. Are you something that me, Tyler, our partner Caleb, and some of the other doctors we work with, we're kind of at a point now where we are following at least like the PATZI protocol as far as doing 6 implants kind of every time that we can. On the mandibular, if you can place straights, and in the upper, if you can place pterygoids, we're doing that for basically every case. You have a couple offices, right? Smart Arches. Are you guys all kind of doing that similar approach? Are you doing standard all-on-4 for patients that get to that first molar occlusion?
We encourage pterygoid anchorage for the maxilla for sure. It's not the easiest thing to standardize surgical protocols because, it's every case is different and there's a rationale for as long as it's thought through and the success rate is good. That's my requirement really. For the upper, 6 implants is what we shoot for. Just because of the bone quality, I think the sort of guidelines we have are very sort of rudimentary. It's like 4 implants, okay, 130 Newton centimeters of toric composite, okay. And that's really it, maybe 2 millimeters plus of implant length. But there's not really much more than that. And what are we up against? We have differing bone qualities, differing amounts of cortication of certain areas, differing angles,
arch forms.
Yeah, I think there's a lot more study that needs to go into it. But for me, my sort of go-to is, upper PATZI, lower 4 plus 2 if possible, without risk of injury to the nerve.
Yeah, for sure.
Are you doing any nerve lateralization for patients that, are in a situation where they can't even get like a standard 4?
It really is case dependent, but that is in the toolbox. I don't like to do them just because the rate of initial paresthesia is very high. It exceeds 80, maybe even 90%. I don't remember what the statistic was. But that to me is enough of a risk to sort of have that conversation of, it all goes back to informed consent. Like, would you rather have risking a nerve injury and maybe one more tooth on your prosthesis? Or would you rather have a more constricted arch and not have to worry about that? It's really their call, So I don't really know what the answer is to that. I don't try to make those decisions for them,
Yeah. Yeah, and it's also it's kind of difficult to really prepare a person for paresthesia if they've never had it. So it's like, is that a problem you really want or not? I mean, it's kind of even difficult to fully inform. It's just, I think it's kind of a case by case thing where someone just has to have, not that I do this, but I would think in my hands it would have to be someone to where I really felt strongly that a shortened arch is still going to have too much of a cantilever because that metal frame is just way too anterior, and I'm not really going to be able to do what I would even call an all-in-4.
No, for sure. You never know how somebody's going to be with paresthesia, just from patient experience, but also my own. I have lingual paresthesia from my wisdom teeth still.
Oh, wow. Okay.
Yeah, I had an OS resident do them when I was a first-year dental student, and I guess, my tongue was numb for several months and started trickling back. But it was maddening at first. Like it was like, I can't stand this, Mm-hmm. And it doesn't hurt, it's just like, what the hell, like tongue is numb. So yeah, I mean that experience to me makes me a little bit wary of like, but then again, like whether it be iatrogenic or just from retracting the nerve or something, some people do go numb for some time and they're fine. So like I don't know. I have no clue as to like how somebody's going to do with that. So if if there is a case where a nerve lateralization is truly needed, just a very thorough discussion, setting expectations. I think that's the most important thing.
Sure, of course.
Yeah, definitely. So I would love to kind of get into a little bit about maybe some questions about your office, and you're more than welcome to share as much as you want and as little as you want. And then let's jump into and talk a little bit about ORCA.
For sure.
So the questions I have are, I'd love to hear a little bit about maybe the volume that you're doing that's just like traditional all-in-4, the volume that you're doing that more remote anchorage like zygomatic implants. And then I'm curious what you guys charge for zygomatic implants. Like, if that's required, are patients paying up front for that? Are they paying extra when you go that route for them? And then, I'm curious what you guys do for patients that fly in for revisions. Are they paying like full price for their cases? Are you guys, so like at my office, we have some patients that travel, and typically like my incentive to them is I'll pay for their hotel and their flight as like a discount to get them to come in for that. And yeah, I'm just curious kind of those specifics for your practice, if you're willing to share.
Yeah, sure. So in terms of like ratio of conventional to zygo, that's an interesting question. I would always, my gut tells me probably 10-ish% are zygomatic cases.
Mm-hmm.
And that has evolved over time for a number of reasons. One, I got better and better at keeping things conventional, being very slick with very limited bone stock. And so that made it go down. But then I started getting a lot of referrals for cases that needed zygo, so it went back up again. So right now I'd probably say anywhere from 10 to 20%. And yeah, it's been good in terms of like traveling patients. We don't I don't know. We haven't paid for flights or anything. At least for most, I forget. But for most, or if not all, I mean, I don't think we've offered to pay for flights or hotels or anything. And
Mm-hmm.
yeah, the fee is sort of the fee. The way that we do, we don't do value based pricing where like we see what the market is charging, we charge the same. We sort of do a cost plus pricing approach where it's like we look at our overhead, we look at what the cost of the procedure is ultimately going to cost us, all those things added up, and then some to make a little bit of money. And so that's sort of how we do that. So it really depends on I guess what kind of deals we have with vendors. But yeah, the fee is the fee. I mean, we don't really discount in terms of like just because they're traveling. And in fact, most of the time, the ones that are traveling to us are the ones that sort of have the craziest cases.
Yeah, the hardest.
Yeah, hardest ones. So like, I also have to think about like how many years of my life is this case going to take off? So like, I have to judge according to that too. So yeah, it's kind of like a game time decision, I guess you could say, in terms of like those, because those are extremely complex. So yeah, that's
for those traveling patients. Do they what kind of what expectations do you give them? So like when they fly in, right? Let's say they fly in on a Monday. They're doing surgery on Tuesday. They get there, maybe you do your records, do your surgery, get them in the prosthetic. Do you send them on the flight the day after? Like how many days do you kind of want them to chill before they jump on a flight? What is kind of your protocol as far as that goes?
Yeah, no, that's a good question. So I don't advocate for going home right away on a flight. especially if we have any kind of sinus involvement. The pressure changes can be painful. And if there's an opening, it will punch through when you go up in the air. So if you guys have ever had a water bottle on a flight, the thing crumples up when you're, so
Yeah.
or expand, all those things, pressure changes can really mess up your sinuses. So I don't advocate for that. I usually tell them to plan to stay for a week initially, so that I can do the surgery or do the records the day before the surgery the next day. Stay a week so I can see you a week later, make sure that things are healing right, and then you can go home. And then after that, sometimes they can get locally a CT scan. I always like to get CAT scans at the stability dip, so 3-4 weeks. I like to see what the bone looks like at that point, and then after that, 2 months later, come back for records, new prototype. That's another week. And then as long as that's good, come back one more time for your finals and goodbye. So that's typically that. It's usually like 3 trips.
3 trips,
yeah.
Going off of that, I'm sorry I'm asking so many specific questions. These are just things that I've like thought of as I've watched your Instagram and people you've treat. I know you've treated some pretty like prominent people that have a good social media presence. Prominent people for you guys. Have you guys seen like a good amount of people coming in from amount of views on some of those videos? And it's something that we've talked about, like maybe doing a case here and there for a patient, like maybe it's it. But I'm curious what.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Yeah, no, that's a good question. I mean, in terms of like the influencers, it has been good. I will say that. But it really there's 2 sides to it, because with sort of TikTok and the idea of like authenticity of your life, which is like very important to influencers, I guess, is it can be good for them, but also kind of bad for people watching, because like if they're having like a complication, or which is
they're going to broadcast that.
Yeah, they're going to broadcast it. People are watching intently because they're scared. They want to see what's going on. That's going to freak them out, and that may actually ultimately prevent them from seeking care. So, it's kind of a catch-22, I think the awareness part of it's good, but I'm not sure in terms of like what people are experiencing, and what kind of decisions are going to make as a result to it. But no, I mean, it has been pretty good. The sort of brand awareness has been positive.
Good.
But it's not like the end all be all. I think it's cool, and it's cool to help people that have that, and hopefully it provides a positive message to everybody.
Yeah, definitely. I mean, it's definitely spreading awareness for, I think no matter what we found in the markets that we're in is that some of these bigger companies, like the Clear Choices and the Nuvias, the people that are pumping marketing dollars into national commercials and stuff like that. It's great for the patients who just didn't know that it was a possibility, right? And then they come into your office and now that they know that it's an option, it's cool that they're able to put that money out there so that we can have that awareness that this procedure exists. Because without that, it's really tough. Most patients, I still have patients that come in and they're like, oh my gosh, I thought that all I could have was a denture or maybe a snap-in, right? But the fact that they can have a fixed prosthetic, they're kind of over the moon about that, and they still haven't seen it. And I mean, for us, I see it every day nonstop. So it's kind of like crazy to think that there's so many people out there that don't even know that it's an option. And that's definitely something that in Tyler's market, Tyler's in Tri-Cities, Washington. I was
just about to say.
Yeah, he just doesn't have like a lot of that awareness. Whereas I'm in Denver, and Denver's like the heart of Clear Choice, right? Clear Choice has been here for forever. So every single person and their mother knows exactly what an all-on-4 is.
Yeah. I'm in a land where people assume that you have to have the teeth pulled first, and then you have to wait, and then you have to get the implants, and then you get your teeth later. In fact, some people will come to me and they just got their teeth extracted with like their insurance, and they come to me like, okay, I'm going to be ready for implants in 3 months. I'm like, buddy, you killed me. Like, you could have just come to the free consult. I could have told you all this. We could have gotten it all out of the way. So yeah, I mean, where you're at in the local marketing, and who's, what kind of fish have already kind of existed in that pond, make a big difference in terms of how some of those consults go and the expectations that come along with it. And that's something I've definitely learned, being in a more, rural part of America. Is like, there's a whole new like re-education that has to happen. But he has people coming in and they're like, so are you doing an all-in-6? You're doing pterygoids? What are you doing? Like a palatal approach guy? You like they're listening to his podcast. I mean, it's insane.
That's good and bad. That's good.
It is. It's a double-edged sword. Yeah.
Yeah. It's like, why'd you miss the pterygoid? Were you not medial enough? It's like, get out of here.
Exactly. I do. I recently had a patient that had listened to every single one of my podcasts, and she just like, before I even said it, she was like quoting stuff I was about to say. And I'm like, all right, well, are we going to do this? Like, it sounds like you sold, like my podcast sold you. But it's a catch-22, right? Because then all of a sudden, like, if something happens that isn't what you want, it's like, oh man, like there's so much more at stake at that point.
Yeah, they're looking for your axial accountability post.
Yeah, right?
Make sure you hit the medial wing.
But I think the reason I brought that up in the first place was just that good and bad. One of the positives of TikTok is spreading awareness for the fact that these procedures exist, but there probably isn't a large population, at least of the people that I'm treating in my office. Like, most of these people in my office at that age, like, aren't really on TikTok. Some are, but a majority are not. But it's good regardless to bring that awareness out there.
Yeah.
Yeah, for sure. I mean, it's going to be interesting what happens in January when it gets banned. I think Apple Store and Android have been told to stop putting it on there January 16th or something like that.
I saw that.
Yeah. So it's going to be interesting to see where short form video merges to next.
A lot of teenagers won't be driving around in Lamborghinis anymore.
I know. I've been working on my TikTok choreo for months, and it's just going to waste. That was my plan B.
So let's talk a little about ORCA. I mean, I would love to hear what the mission of ORCA is, what people can expect, maybe at what point you'd recommend people going. I know that you guys have kind of like you can just watch, or you can go and actually get your hands wet. If you could give us a little overview of that. A lot of our listeners are kind of at the stage where they're doing a lot of all-in-4, but maybe they aren't getting into remote anchorage, and they're at that point now where ORCA would be an option for them.
Yeah, for sure. ORCA is a very sort of unique and special thing. I think it's turned into something really cool. It sort of started with just hearing about the problems over there. So a very common practice. There's a large population that live in villages where they have shoddy electricity, no internet, stuff like that. And so a very common practice for those sort of populations is to when they turn to become teenagers, the parents actually get enough money to send them into the city, pull all their teeth, put them in dentures, bring them back, because a toothache is like a life ruiner. There's no access to basic care there. So like that's sort of what's going on over there. So decades later, no bone, so, and then after that, no tools to help these people because, nobody had placed Zygos down there. So, they've been sort of walking around like this for a long time. And so, I heard about this because my partner in ORCA, Eldad Drury, he went down there to do a singles implant course. He met Rodrigo Carriaga, who's the head of implantology down there. He trained up at NYU did the implantology fellowship. Mm-hmm. Amazing people. So they met each other and they sort of talked, and Eldad had known that I wanted to do something overseas to help, help people. I had always heard about CE courses that were sort of in it for sort of the education only. And then there's no restorative plan, like it's crazy. You're just basically cutting people open and leaving it, so like it's crazy to me. And like not having follow-up, they're having problems, not getting prosthetics. So that sort of piqued my interest because this is at a university. This is at the top university in Guatemala, University of Francisco Marroquin, which is highly respected. The facilities are unbelievable there. It's the nicest dental school I'd ever been to. And so that really was interesting to me because, like, okay, it checks the boxes. Needing a needed or population in need, a great facility, and people that care. Like that. Those were the sort of basics that I needed. So we went down there. I placed the first zygomatics in Central America a few years ago.
Nice, congrats!
Yeah, and this patient that had been edentulous, trying sinus lifts over and over and over with no results for many, many years. Like I don't remember the number. It was like 30 something years, just no teeth. I go in there, do a quad, put her in teeth. She's just like crying, like it's, and so like that I needed to also convince the school that this was, because like nobody had heard of this before. So like, come here and do what,
Yeah. Mad scientist.
Yeah, exactly. I was like, I have to make sure this case goes well, like, or else like this is going to be horrible. So, but we nailed it. We got it done. German Lee, my lab tech I've been working with for a long time, came with me, did the conversion. We did it in the OR under general, and it went very smoothly. Since then, they were like, okay, we believe in it, but there's a lot of liability. So we're like, okay. So, the expense that we take on by doing this is rather high. Because we have to provide for liability and pay the school, which is fine though, because I want to make sure that the patients have really good follow-up, really good care afterwards. So that's sort of what it turned into. We're like, okay, we can fund this through education. So I know a bunch of guys that are really good at this. Let's all get together. We'll have a great time. We do level 2, which is conventional all-on-4. We do that in under anesthesia in the clinics. It's under moderate sedation, sort of like a practice setting. And so we do that there. It's 1-to-1 mentorship, which I don't think anybody else can say. It's 1-to-1 mentorship with one of the best people out there, very experienced, and they're sort of over your shoulder. So it's a very orchestrated thing because we also have a prosthetic course going on at the same time so that we can get everything done as if we're in the practice at home. So the prosthetics course is led by Dr. Adam Hogan, Dr. Keith Klaus, two of the very well-known guys.
Yeah, very good
at this.
We're familiar.
Yeah, and they're just great people too. That's like one of my top rules is no D-bags. Like that's a very important rule for me. So we have those guys, and they teach the prosthetics course. So sorry, I'm kind of all over the place, but the way that it works chronologically is first the digital prosthetics team with the participants comes in the weekend before the course starts. They take all their records, the pre-records on the patients. Over the weekend, design circuiting done, and then on Monday, that's when we start. So level 2 and 3 run simultaneously. Level 2 is the conventional stuff. So we pre-select these cases months before we get there to make sure it's appropriate. And we do it one-to-one mentorship. So the digital team will come in, place the markers, do the initial scans, and then the surgical team will come in, place the implants, and do whatever surgery is needed. And then the digital team comes back in with photogrammetry. Sometimes we do SegMark with the CT alignment technique, and do the other scans. And then they get teeth right away. So that's the protocol. On the level 3 side, it's a little different. It's as you guys know, it's more invasive. So full scope remote anchorage, full scope. So anything from zygos, pterygoids, transnasals, multiple zygos, all these things. So that's run in the operating room. It's the OR. So it's run with one anesthesiologist each in each room, not like, my experience.
Yeah.
And it's nasal intubation. We scrub in, we go in, again, one-to-one care. So you're paired up with a participant. The faculty sits at the head. They split the case. So one side does half, the other side does the other half. And from there, same sort of protocol. Digital team comes in first, places the marker, scans, surgery is complete, post-operative scans, wake up, go. And we do it all day long. For 4 days. And after that, we do a debrief on the last day. We have fun each night. It's a great time, really good, awesome. Sort of very good spirit, because everybody there's there for a reason. It's a purpose-driven sort of thing. And at the end of the course, every time we go down there, we're roughly at like the 55 arch, 60 arch range in terms of how many we've done that week. And we measure each time the amount of edentulism we stopped. So each time we go down there, it's roughly 1,200 years of edentulism that we've ended that week, which is a pretty cool statistic. So it's
very cool.
Like 20, 30 years each patient has not had teeth, So that's something that we're very proud of. We're really excited because we're ramping volume up soon. So the university has, seen our success with how many people we've been helping. So they're actually building 4 additional operating rooms for us. So we're going to ramp things up in 2026. So that's really cool. We do this roughly twice a year. We're looking into increasing that frequency. Another thing to note is that we are never sort of limited by one vendor. So it's not one vendor sponsoring the whole thing. And we did that because we didn't want them to control, the educational process, the protocol. And that way people can sort of see what is actually best for that clinical application. So we have many different vendors that provide supplies, and these are all people that actually care, they care to donate products to help these people out and be a part of something that is sort of beneficial for humanity, so and of course they get new customers, hopefully, and we want to help support the sponsors too by helping them. And so it's a very sort of symbiotic thing that we have going on. It's very well cultivated, I think, because people involved in it. But yeah, in terms of education, we wanted it to be the best educational experience. And so there's no judgment. We try to keep it very, very friendly, and the learning experience to being optimized. So that's why we do the zygos in the OR under general. They are paralyzed, because we don't want to have to converse about hey, you need to give more local here, or hey, they're really feeling it, or so we want to be able to talk freely and not freak the patient out if somebody's not at the right trajectory, So it's
you're in the eye.
Yeah, exactly. Yeah,
that's orbital fat.
Yeah, hopefully not. But yeah, that'd be a bad day. Luckily, we have never done that. But yeah, our success rate's good. We do measure that. We do care about that. Patients are being well taken care of by the residency programs. So the prosthodontic residency program. And in fact, we are planning to launch the oral surgery program there because they don't have one. one of the things we do on the side at the university, sort of through ORCA, is we do a lot of odd pathology. So in Guatemala, there's not much access to like really upper end oral maxillofacial surgery. So, a bunch of my friends, Kathan Patel, Steve Yusupov, Zach Brown, which is also an ORCA instructor, and Joe Camarata, who's an oral surgeon and plastic surgeon, which is crazy. We all go down to sort of cut out these enormous ameloblastomas, huge tumors. We did a myxoma of this one girl. I have the model right here.
Oh, sweet.
This was a 9-year-old girl. This is her jaw.
Oh my gosh.
Jeez. Yeah. I think I may have seen this case. That's insane.
Yeah. So obviously this is from lack of access to, would you ever see this in the States?
No chance.
Right. Like no chance. And so like, that's the sort of stuff that goes down there. So on the side, we do a lot of these cases because the faculty there bring it to our attention. Like, hey, can we help this person? So I'm like, yeah, let's get all this stuff down, get all these people down. And we go to the pediatric hospital, do these fibulas in the OR. We've done a bunch already. We're looking into getting cleft lip and palate. It's sort of become like this thing where like, it's just driven because we want to help these people out, And so it's been really cool, and we have the resources and connections to make it happen. So why not? So that's sort of the long and short of it with ORCA. We're really excited to see where it goes. We've gotten a lot of interest from other countries. So we're talking with people in Ghana through Tarun Kirpalani, oral surgeon in New Jersey. He's ORCA alumni. And we had contact in Trinidad. We talked to a team in Puerto Rico. So there's a lot of sort of interest there. So we'll see where it goes. But, again, It's very strict in terms of what we need is great follow-up, great, patients that need it, and us being able to do it. So,
yeah. Yeah, I mean that's amazing what you guys have been able to build, and you talk about picking a field of dentistry that has a lot of impact, and that's it's just a crowning achievement of doing the most impactful kind of dentistry that we can do at the top of our license. So I mean that's really amazing, especially to go to the areas of need where they were light years away from having that kind of care evolve organically, and you've been able to institute that, and obviously you've had a lot of help, of course, but I know you must be very proud of what you guys have been able to do. That's really cool.
Yeah, absolutely. I think it just sort of goes, that's just what I want to do. And that's sort of the idea behind Smart Arches too, is like, okay, like we could charge 30, 40,000 an arch. I've heard of places in New York charging like $200,000 for a double.
Oh my
God. Believe that, dude? Like, are you serious? Like, oh my God. So like that, that's like the sort of thing with us is like, we all found the hack of digital, which reduces our overhead.
Of course. Yeah.
It increases success. And so like, instead of, value-based pricing, higher, we made the investment, all these things, better results, higher price. But for us, we actually lowered it so that we can pass it on. Yeah. More people, it's a good thing. I'm also trying to figure out a way to fund charity cases for that too. Mm-hmm. Dr. Brady Smith, who you guys may know, he's actually doing stand up at the ORCA.
Great.
Really?
Oh, really?
Yeah, you guys have to follow him. Hilarious, dude. He runs something called the Halo Dental Network.
I have heard that. Yeah.
Yeah, they give out they give funding or connections for people to get their teeth done by somebody who's willing to be philanthropic. I've just been trying to figure out how to get consistent funding to do that in the US. It's just been a challenge. I did meet some really interesting people that, we can really make a difference if the strategy works out. But time will tell.
Sure. Yeah. So we brought up the symposium there. I definitely want to make sure that we talk about that because that's coming up here pretty soon. I think it was January 17th and 18th in Las Vegas. We're doing there. I've seen the lineup. It's incredibly impressive, the kind of speakers that you've gotten to come through. So if you wouldn't mind giving us kind of an elevator pitch of what people could expect if they should attend.
Yeah, we wanted it to be the symposium to be a little bit different. For one, a lot of symposiums sort of talk about all the same stuff the whole time.
Yeah.
And that like maybe you pick up one or two good things every hour. Like
Yeah.
that's not very efficient. That kind of bothered me, and so we wanted to do something a little different where we had many different topics from people in that industry, and people that actually practice this stuff. And so get perspectives from all different angles and get perspectives from people that you normally don't talk to. So, we have the Prost side with Dr. Sven Bone. If you guys don't know him, you need to talk to him. He's not only a prosthodontist, he's also a mathematician and a physicist. Like the most credible person. So he's talking about that, about pros. We have a slew of oral surgeons at the top of the industry. We got Juan, we got Camarada, we got Vichy, we got Steve Yusupov and Patel talking about microvascular and implants. Kimra was talking about the facial skeleton, as it relates to full arch. We have ENT. So my brother-in-law is a fellowship trained rhinologist. So the guy that he's the guy on the other side of the curtain, the guy behind
yeah.
You know what I mean? So he's going to talk about sinus disease and how to manage sinusitis as it relates to zygos, what happens to oral antral fistula, what are the actual options? We always hear FES, but there are many different types of sinuplasty, So he's going to talk about that too. Anesthesia as well, from my anesthesiologist, Dr. Gobron. He worked in cardiac for a very long time, so he's very well versed in this stuff. That's sort of it. We wanted it to be in a very cool place, which is going to be in Las Vegas at the Wynn Hotel. There's going to be a lot of different sponsors, a lot of great people there that you can talk to about products. And then at the end of each of the days, we're going to have a great time. I think a lot of the people that sort of come to ORCA events we're all sort of intermingled. We all know who each other are, but maybe not all that well. And so I think it'll be a nice experience of not only education and learning cool stuff, but also networking. And at a cool place. I think, especially in January, we wanted to be somewhere where the climate's kind of, nice. I can't stand January, February. So you guys ever notice the ORCA events are in January and February?
There's no coincidence.
Yeah. So that's sort of that's how that works. But
cool.
But we're really hoping that people have a great time. We're looking into throwing a pretty cool party on Saturday. So and then Friday, I think there's a bowling event going on at night. You guys both coming?
So Soren's going to be on vacation. I don't know what he was thinking. But yeah, I definitely intend on coming. So
Tyler and Caleb are there. They're instructed to take lots of notes and fill me in on what I'm missing out. But I saw it I think you guys posted it probably a year ago, maybe 8 months ago. And I was the first one to post in the group. I'm like, guys, we got to make this happen. And then of course I forget about it, book my vacation. And I'm at the point now where if I back out of the vacation, my girlfriend would not be stoked with me.
All right. This is the plan. We're going to get an Optimus robot. We're going to put an iPad on the head and you're going to face it the whole time as you walk around the place.
Yeah, that's exactly. We'll call up Elon and one of those robots he had at his convention.
Oh man, that's great. Yeah, well, I'm sure it's going to be a really good time. And where can people go? I mean, you know what? We'll put something in the show notes to help people figure out where to sign up for the course and everything. I'm absolutely stunned by the lineup. I've never seen such a star-studded cast of full arch folks. You got Dr. Ole Jensen, David Zellick. I mean, you got some real OGs in here. This is crazy.
All the guys. I mean, I can't even list everybody because it's all people that have deserve their own sort of
They could all have their own symposium. Yeah.
Yeah, exactly. So, Zelig, Oli, all these guys are just unbelievable. Not only speakers and intellectuals, but also people. Like they're good people. So again, that's like our requirement there. But yeah, I mean, looking forward to seeing you there, Soren. Hope you enjoy your time with your girlfriend.
Yeah, it's been like a couple years since I've gone on a legit vacation, so it'll be good. I need it. I need to take a week off, but I'm very annoyed that it happens to be on the weekend of ORCA.
Well, we'll let you know when the next one is.
I'll definitely be there. Yeah. And Tyler and I will definitely be at the ORCA in Guatemala at some point as well.
Yeah, for sure. Oh yeah, I forgot to mention, like if you're not for people that don't want to into live surgery, you can just come down and observe, be with us.
Oh, sure.
Wash stuff. That's also an option. So just orcaglobal.com is the website for all that stuff.
Perfect. All right. Well, Dr. O, thank you so much for sparing some time to come on and talk about your story, your impact on not just the dental world, but the world, and what you're able to do, and taking what we do and democratizing it to so many needy populations is an amazing thing. I'm so happy to hear that it's grown so much since even just the last time we spoke. So that's really amazing. I hope everyone sees that ORCA is really the nexus of the people that are really practicing this at the top of our field, and I hope people are looking into that. Hopefully going to a symposium, and they might find themselves in Guatemala or Tahiti or wherever else you were talking about going with ORCA. So again, thank you so much for coming on. We really appreciate it. We hope to talk to you again soon, and I can't wait to see where you guys are next.
Yeah, sounds good. Thanks a lot, guys, for having me, and great to be here.